We are live now, ma'am.
Yes. A very warm welcome to all the esteemed faculty members from Amogs. We are the Amogs Emergency Obstetric Committee in association with Satara, Sangli, Miraj and Y OBGY societies conducting the fifth webinar in this series with the topics of everyday use so that we carry the knowledge to every nook and corner in across all the societies of Maharashtra. This webinar is a brainchild of Dr. Sneha Bhuyar Madam, who is the chairperson of the Amogs Emergency Obstetric Committee. I would now like to introduce ma'am and ask her to welcome everybody. Ma'am, can you, please. Ma'am is the current chairperson of the Emergency Obstetric Committee and she was the past chairperson of the Medical Disorders of Pregnancy. She has been the past chairperson of the breast disorders in FOXY also. Ma'am, I would like to you to speak and invite everybody for the inauguration ceremony, please.
Yes, thank you so much, Monica, and a very good evening to one and all. Respected President Amogs, Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, sir, the immediate past President of Amogs, Dr. Rajendra Singh Pardesi, sir, who is traveling from Umarga, so he could not join, and chief guest for today's program, Madam Sunita Tandurwadkar, Dr. Parikshit Tank, guest of honor, Dr. Sagar Kataria, and our dear friend, Dr. Girish Mane. Today's faculties, respected Dr. P.K. Shah, sir, dear friend, Dr. Shantanu Abhankar, all the esteemed panelist chairpersons, and of course, the presidents of Sangli Miraj Society, Dr. Suman Kulkarni, Secretary Dr. Pradeep Dorle, President of Satara Society, Dr. Vilas Padtare, and Secretary Dr. Kiran Sonwalkar, Dr. Monica Kuloli, the past president of Miraj Sangli Society, Dr. Shantinath Kole, who was also there with us in just before this program, the president of Ichul Karanji Society, Dr. Varsha Lahade, our dear friend, past president of Nasik, and Dr. Kanchan Joshi, who is the Amogs youth coordinator. Of course, my right and left hands, dear friends, Dr. Madan Kamre, the Amogs chairperson for Sexual Medicine Committee, and Dr. Monica Umbadan, the zonal coordinator. A warm welcome to all of you. Friends, though since last 2 years, I have been working for Amogs as chairperson, but that was for Medical Disorders Committee. And of course, we could reach not only the societies of Amogs, but each and every society of India, including the Northeast. Thanks to Dr. Rajendra Singh Pardesi for all your blessings and support. And it's my pride and privilege to introduce and invite President Amogs, Dr. Kiran Kurtakoti, to deliver his precious, I would say, the precious words, and of course followed by Dr. Bipin Pandit sir, the Secretary of Amogs.
Thank you. Thank you,
Yes,
Sneha.
yes.
Sneha,
Thank you so much. Over to you, Dr. Kiran, for your precious words.
Thank you. Thank you so much. You know, in the era of webinars, we have been webinar hopping. Practically, this is the third webinar of today. But whenever it is Amogs societies, you know, ghari aल्यासारखं वाटतं. So thank you for inviting us. And really, you have been doing a great job as the Emergency Obstetric Care Committee chairperson. You have done a great job as a breast committee chairperson also. And really, we look forward to all the topics today. My respects to Dr. Sunita Tandwadkar, President-elect FOXY, who is today's chief guest, and of course to Parikshit Tang, also the chief guest of today's function. And warm regards and welcome to all the president secretaries of all the societies of Satara, Sangli, Miraj and Y. So this is a webinar which is held under your aegis, and we really look forward to our speakers, Dr. P.K. Shah, Suman, and my friend Shantanu and everyone. And really, it's really a nice feeling, warm feeling to be back to the Amogs platform. So thank you so much. And I see Parikshit. Parikshit, slightly belated birthday wishes to you. So
thank
with
you
this,
so much.
this small things, I mean, with the small talk, I mean, I request Neha to get on with the proceedings.
Yes.
And wish you best, very, very best of luck in all your endeavors in the years to come. Thank you.
Thank you so much, Dr. Kiran. And I would just take this opportunity to invite Dr. Bipin Pandit, sir, the Secretary of Amogs, to have a few words for this program. Sir, over to you, sir.
Thank you, Dr. Sneha Puyar, for inviting me and being part of this excellent seminar. And I'm stuck up in the traffic and enjoying the Bombay traffic now. And Dr. Kiran Kurtakote, our president, Dr. Sunita Tendulkar, our chief guest, Dr. Parikshit, guest of honor. All are welcome for this excellent topic and seminar. And I'm sure people who are listening, all the members will get enriched with knowledge. And thank you very much. All the best.
Thank you so much, sir, and welcome, Dr. Parikshit.
Dr. Sneha, if I may. Yeah, if I may.
Yes.
Since Sumant is there and Dr. Pradeep are there, they have promised to take the Amogs Zonal Conference in Sangli. So on this platform, I give them an open invitation. Whenever it is possible, feasible, please hold it. You can hold it with any kind of oration. We have no problem at all. But just get it done ASAP. Thank you.
Yes. Thank you so
so
much.
much.
And now, Saiti, can we have Madam CV? I would, apart from the formal introduction, what is there on the CV, I would just say that Madam is such a determined, the daredevil and dedicated Foxy, and the brain and beauty, of course, the President-elect Foxy, Dr. Sunita Tendulkar. I think you just named the organization and she has headed it all. So without much ado, I would like to listen to your precious words, Madam. And over to you, Madam Sunita. Madam, please unmute yourself.
Thank you so much, Sneha. Kiran म्हणाल्यासारखं, Amogs मध्ये घरात आल्यासारखं वाटतं. And when we are with Satara, Sangli, Miraj, these societies have helped me from the bottom of their heart. Sagar, I can't forget those days, and I will never forget the wholehearted support by entire, single vote you collected from your society. And I am today Foxy President-elect. It's all because of you all friends. Shantanu, I know you were not well, still I disturb you. Pradeep, Sumant, I'm really thankful to all of you. Secondly, about the Amogs. घरात आल्यासारखं तर वाटतंच, पण घरचा माणूसच प्रेसिडेंट आहे म्हटल्यावर मला अजूनच घरात वाटतं. I'm so happy to be today on this platform of Amogs, who supported me so beautifully when I needed it. And Amogs will always support the Amogsians. So Sneha, I can see even Varsha Lade, who is going for the Amogs for the Foxy election, and Girish, you have done such a great job, and you are also going to be soon somewhere. And whichever year you all select, I'm sure the whole Amogs will be with you irrespective. Parikshit Chand, chief guest, along with me, lovely. He will be working as my everything in Foxy. He promised me. He will be my right hand, left hand, guiding me, helping me. He has intelligent suggestions always. And that's why I requested him to take a rest this year. With Dr. Jaideep Khan, he may not work. He may work in the hospital, but with me, he will work in a Foxy office very much. We have a guest of honor, Dr. Sagar Kataria. Again, a very dear friend, very dependable. And I have not observed the presidencies of Amogs so closely, but I know, Sagar, sometime we will be seeing you there in the queue as a president Amogs. Definitely, because I have seen you doing such a great work. You, Varsha, Bipin, Bipin to now climbed up the ladder already, but you and Varsha, I'm definitely sure that one day you will be heading. Now, Sneha, you, in whichever committee we give you, whether it is a practical obstetrics, emergency obstetrics, breast committee, तूने 4 चांद लगा देती है, जी जान लगा के काम करती है स्नेहा. And I'm so glad. And I know you wish to be in Foxy, but Foxy also need very hardworking, deserving people. So for me, you are going to be my vice president, whether on chair or not on chair. doesn't make any difference. You will be working with us. Today, when you have Dr. PK Shah talking about shoulder dystocia, and Shantanu talking about PPH, and you yourself will be taking a I think these 2 hours will be absolutely the treat for everyone who joins to this. And I'm sure maximum people will enjoy and be with you with such an eminent panelist. Thank you once again for giving me an opportunity to meet my family, my Amogs family once more with you all. Thank you.
Thank you so much, madam, for your gracious presence and, of course, your precious words as well. Thank you. Thank you so much. Now I take the privilege to introduce our dear, Dr. Parikshit Sang. Apart from this, all of you know he's the treasurer of Foxy, but apart from this formal introduction, I would say he's such an intelligent, extraordinary person with a very kind heart, and of course, innovative and calm and composed person, I would describe him. And Dr. Parikshit, we are very eager to listen to your precious words. Over to you, Dr. Parikshit.
Thank you. Thank you, Dr. Bhuyar, for this kind invitation. And, typically chief guests are supposed to provide words of encouragement to the people who are organizing programs. But I think you have made us completely redundant because you don't need any encouragement at all. You only need congratulations. I think today's program, what the Emergency Obstetrics Committee has envisioned, has wonderful speakers. It has Dr. P.K. Shah, Dr. Shantanu Abhyankar, a wonderful panel, and all the panelists who are going to participate. Uh, I love emergency obstetrics simply because it is the daily routine for almost every obstetrician. And for that reason, I feel that we can never have enough of experience sharing and knowledge distribution on this subject. So I wish this committee and this program all the very best. And it's a delight to share the platform with wonderful people. Dr. Tandulwadkar is here, Dr. Bipin Pandit, Dr. Kiran Kurtakoti is here, and Dr. Mane, Dr. Sagar Kataria, all the wonderful chief guests of honor. And of course, thanks to Monica for always coordinating and being in touch. Thank you.
Thank you so much, Dr. Parikshit, for that wonderful words of appreciation and encouragement, of course. Thank you so much once again. I take this privilege to invite Dr. Sagar Kataria, Saiti. Yes, Dr. Sagar Kataria, all of you know him by the Mahabaleshwar conference, I think, the Satara conference, and of course, the Mahabaleshwar conference. Also, he has a major role with Shantanu Bankar, and he's a senior consultant from Satara, past president of Satara Society, and a very active person, as all of you have just heard, great caliber. So over to you, Dr. Sagar.
Thank you, Dr. Sneha Bhuyar. In this star-filled galaxy, I'm a very little star, and no need of introduction for me. I wish very best for this webinar. This is a wonderful webinar in the sense that it holds to the core of our OBGY practice. The emergency obstetric is always a core for any obstetrician working in the field of OBGY. And all the topics chosen and the panel is all about the emergency obstetric. And the work done by you is tremendous, madam. And I wish you all the best for your future tenure. Thank you for calling me as a guest of honor, though I don't feel I am that much great personality, but thanks for the honor. And especially thank you for involving me the nearby societies like Satara Society, Miraj, Sangli, and Y people. So thank you very much.
Thank you so much, Dr. Sagar. And here comes the turn of inviting my younger brother, Dr. Girish Mane. We belong to the same place, and all of you know he's a singing star from Yavatmal, past chairperson of Adolescent Health Committee, Gynae Committee of Amogs, as well as Foxy, and so many awards and accolades to his credit. So Girish, we are eager to listen to you. Over to you, Girish.
Yeah, thank you very much, madam. And let me share one thing to all the galaxy that Sneha madam is right now. She's president of IMA Yavatmal also, and not only Amogs and Foxy, but she is taking the academic activities for IMA Yavatmal. I mean, for the different specialities of Yavatmal doctors also. And she organized one very big sports event, sir and madam has organized, which was a very big hit in Yavatmal. So thank you very much, madam, for kind words. Good evening, respected Dr. Sunita Madam, Bipin Sir, Parikshit Sir, Sagar Sir, Shantanu Sir. Good evening to all the faculties, all the chairperson, all panelists. Today, actually, I want to tell something about the shoulder dystocia. This is a condition where you cannot do, I mean, you don't have any other management other than to manage the shoulder dystocia. Because in shoulder dystocia, neither you can go for cesarean section, and you are having very little time with you, and you have to take out the baby without any injury at any cost. And unless and until you happen to be a person handling a shoulder dystocia, one cannot I mean, get an idea of how it is important to know about the shoulder dystocia. And it will be a wonderful opportunity to listen from a very experienced person, Dr. PK Shah, about shoulder dystocia. Same thing is with the PPH. Every patient is liable patient for PPH, and unless and until you are capable to handle the patient of the PPH, you are not a complete obstetrician. And of course, near miss cases, everybody they are facing in their practice every time. And Dr. Sneha is having a very good panel on this, and I have already gone through her panel before this. So I extend my sincere thanks to the organizers, especially Dr. Sneha, for this invitation. And I extend my best wishes to all the panelists, all the speakers, all the chairperson, and thank you very much. Over to you, ma'am.
Thank you so much, Girish. And I declare that this program has been inaugurated by all the stalwarts. We have received the blessings of the God Almighty and our seniors. And I hand over the forum now to Dr. Monica as well as Dr. Madan Kamre for the further proceedings in the academic session. So thank you so much, all of you, for being here and for your precious words. Thank you.
Thank you, madam. Thank you.
Thank you, Sneha ma'am, for giving me an opportunity to coordinate this session. Kiran sir, Bipin sir, Sunita madam.
I just inform you that Dr. PK Shah sir is busy as chief guest in the other webinar, and he will be joining soon. So I think we have to take Shantanu's talk first.
Sure, ma'am. Yes, ma'am. Kiran sir, Bipin sir, Sunita ma'am, Parikshit sir, Girish Mane sir, and Sagar sir, thank you so much for your wonderful words of wisdom, and thank you for gracing the occasion today in this webinar. We move ahead with the academic session, that is the topic on PPH bundle by none other than Dr. Shantanu Abhyankar sir. The chairpersons for today's session are Dr. Sheetal Nath Kole sir. He is an ex-lecturer at Vanless Hospital at Miraj and practicing gynecologist at Ichal Karanji. He is currently the president of Ichal Karanji Society. We welcome you, sir. Our next chairperson is Dr. Keval Patil, sir. He is the fetal medicine consultant and an obstetrician at Miraj. He successfully performed fetal intervention procedures over a period of the last 5 years, and his specific areas of interest include recurrent pregnancy loss, the first trimester scans, and the management of IUGRs. We welcome you, sir. Our third chairperson for this session, Dr. Kiran Sonwalkar, sir. He is the secretary of the Satara OBGY Society, and he's been a member of the Foxy Medical Legal and Ethical Committee, as well as the Amogs Medical Legal Committee. And he has a past experience as a PCP NDT medical officer in the Satara District Hospital. We welcome you, sir.
Thank you.
I request the chairpersons to please introduce Shantanu, sir. Sheetal, sir, are you there?
The chairperson can.
Yeah.
Dr. Kiran
Kiran sir, can you please introduce Shantanu, sir?
शंतनू सर आमच्या साताऱ्यातले, यांची वेगळी विशेष अशी ओळख करून द्यायची काही गरज नाही. सातारा, सांगली, मिरज हे जवळ असल्यामुळे सगळ्यांना ते परिचित आहे. आम्ही त्यांना म्हणतो आमचे साताऱ्याचे ते जेम्स बॉन्ड आहे. अष्टपैलू व्यक्तिमत्व. सर वॉज प्रेसिडेंट इन सातारा OBGY सोसायटी 2015-17. Sir was chairperson in Foxy in 2011-13 Sexual Medicine Committee, organizing chairperson of UA Foxy 2010, has more than 8 million plus views on YouTube channel, contributed many chapters to the specialty textbook, delivered several oration. As we know, sir is writer, orator, blogger, innovator, and TED speaker. सर हॅव गॉट पुस्तकांसाठी मराठी साहित्य परिषद आणि विज्ञान परिषदेमध्ये पुरस्कार पण मिळाले. सो आय वेलकम डॉक्टर शंतनू सर फॉर हिज लेक्चर पीपीएच बंडल्स.
Yes, Shantanu, I think you need to unmute and please see whether you can share your screen. Sir has also joined, I think, PK Shah sir. Sir, good evening, sir, and welcome.
Good evening. Thank you.
Sir, are you ready? Should we start your talk?
Whatever, if Shantanu is ready, let him finish PPH bundle.
Okay, Shantanu.
Already has been introduced.
Okay, I'll begin, no problem.
Okay.
Yeah.
Are you seeing my slides? I'm trying to share the
Not
screen.
yet, sir.
Okay, just a moment. Maybe now.
We can see you.
Yeah. Yeah.
Yeah.
Yeah.
You can make it slideshow.
Yeah.
I think I have. Anyway.
Yes. Yes.
Thank you, Dr. Sneha and all the other organizers for having given me this chance. It's been a long time that I have been away from such fora and podiums, and it's nice to be back with all my friends, colleagues, seniors, teachers. So wishing you a very good evening. I'll straight away go to my talk. Management of postpartum hemorrhage in low resource settings. And before I begin with the slides proper, I would like to say that I'll recite a poem that I have composed for my staff. Since I work in the low resource settings, I find this most helpful. And unless they recite the poem by heart every month, I don't issue the paycheck. And this is a very, very effective prophylactic method against PPH because when it happens, they know exactly what to do. So it's in Marathi, of course, because none of my staff members can follow anything else but Marathi, perhaps an inkling of Hindi. So it goes something like this, and it's sort of a stepwise protocol. PPH झालं मारा बोम, that is call for help. PPH झालं मारा बोम, high risk करा नोंद, so take proper consent. द्या हेडलो, द्या lithotomy, catheter घाला bladder मध्ये. That is something that most of the times is missed, that one has to catheterize this woman because when the bladder is empty, the uterus is more prone to a proper contraction and retraction. So that comes first. That's the simple thing that our staff can do and they need not wait for us to be there. 16 number intracap, दोन्ही हातांना लावा stat. Now some of these lines are an overstatement. I can understand that. But please remember that I am working at a taluka level place in a lone standing clinic with me as the only qualified and the most qualified person on campus. So I have to do this. So please modify the lines according to your needs. This is what I have formulated for my clinic. 16 number intracap, दोन्ही हातांना लावा stat. So it has to be number 16 and both hands because you have to secure an IV line before the patient goes in shock. घ्या भरपूर blood sample. That is the first thing that they have to do and not start the IV line before blood samples are taken. And my instructions are taken every possible tube that you have in the labor room. So if there are 4 types, take it in all 4, doesn't matter. So 16 number intracap, दोन्ही हातांना लावा stat, घ्या भरपूर blood sample, मगच सुरू करा रिंगरचा नळ. It is ringle acted and it has to run like a tap. So both these messages are very clear. मसाज करा, क्लॉट काढा, टाके घाला झटपट. So that's the next step. Massage the uterus, clot काढा, टाके घाला झटपट if there is something to be sutured. रक्त साकळतंय का बघा. Now that is something that I insist very much upon. I have taught my staff to look at the spills on the ground, see if there are clots, see what is coming out, if it is just watery blood or is it clotted blood. So if you don't notice that there is no clotting, then it is a deadly thing. रक्त साकळतंय का बघा, नाहीतर येईल नाहीतर आफत. 4 अँप्यूल पिटोसिन बाटलीत टाका, इंजेक्शन मिथर्जिन IV ठोका, प्रोस्टोडिन द्या मांडीमध्ये आणि 600 मिलीग्राम सायटोटेक गांडीमध्ये. That how it goes. And oxygenचा चढवा mask. That is something that most of the times we miss to do. The patient needs oxygen mask. ऑक्सिजनचा चढवा मास्क पेशंटला ठेवा गरम खास. So in chilly winter season, it is really very difficult for the patient to be, without clothes, wet all over, bleeding, in shock. And if you don't keep the patient warm, the shock worsens. So maintaining the temperature is very important. So ऑक्सिजनचा चढवा मास्क, पेशंटला ठेवा गरम खास, रक्त चढवा, डोकं लढवा, राहा सदा दक्ष, बी ऑलवेज on your toes. आई वाचेल बाळ जगेल हेच आमचे लक्ष. That is our aim. So since I have now given the take home message, I can now the slides. And since I am speaking to this August gathering of OBGYNs who have been into practice for so many years, most of what I say here is just a revision, which of course is necessary and important. Anyway, it's a nightmare to have a patient who is bleeding and bleeding all of a sudden and quite a lot. We all have suffered this nightmare sometime or the other. So though the definition says that it is more than 500 ml postpartum or more than 1000 ml post-cesarean, we all know that these definitions are not of much use. And practically, if the patient goes in shock, it is important. And if she survives that particular bleed, whatever the volume, then that is good enough. Maternal mortality and PPH. PPH happens to be the leading cause of maternal mortality in our country and across the globe. There are two types, of course, defined in our textbooks, primary and secondary. The classification is important because the causes are different. So the primary or immediate PPH that happens within 24 hours of delivery is usually due to atonic. Most of the times it is atonic PPH. That's the most common cause. Or it could be through tears or trauma. It could be due to tissues retained in the uterus, incomplete placentas, membranes and whatnot. And it could be due to issues with the thrombin. So just to have those 4 T's, we have tone, tears, tissue and thrombin or coagulopathy. That is the common cause in the primary PPH. In the secondary or delayed PPH, which happens beyond 24 hours and up to 6 weeks postpartum, that is up to 42 days, it is usually infection uterus and retained placental fragments again. So these are the 6 major causes of maternal mortality. And you can see that the huge chunk of this pie belongs to the blue, that is hemorrhage, and the red one, that is 19, is eclampsia. And of course, both are intimately related. Patients with PIH and eclampsia are likely to bleed. This is the geographical distribution of maternal mortality in India. You will find that it is higher in the Bimaru states and it is much lower in Kerala, in areas of Tamil Nadu, most of Maharashtra, Telangana, and such areas. But there's good news. Maternal mortality is dropping precipitously thanks to all of us, all our colleagues working across the country. And very soon, I believe that we should be reaching less maternal mortality across the country. And sooner than what we took now, we should reach into single digits, which is possible. Prediction and prevention of PPH. I wouldn't call this prediction actually, or we'd say apprehension or expecting PPH. High risk factors related to the uterine distension or labor related factors such as induced labor, prolonged labor, augmented labor, use of uterine relaxants such as deep anesthesia. Now we are not using halothane any longer. So this is not, and ether is out of question long ago. So this is not much of an issue. And then there are intrinsic factors such as previous history of PPH, obesity, etc. Prevention, you have to avoid prolonged labor and the World Health Organization has advised us to use the active management of the third stage of labor. Here, just a moment. Yeah. This slide shows the risk categorization. There are the low risk patients which everybody would want to handle and deliver and admit in their own setups. Then there are the medium risk ones. I need not list what are the factors of medium risk, but the high risk ones, I believe that we should go through the list. So one who has 2 or more medium risk factors, active bleeding is more than a bloody show. So there is likelihood of either the DIC or some other cause that is causing this particular bleeding. Suspected placenta accreta or percreta, they're very high risk. Placenta previa or low-lying placenta, again, very, very high risk. Known coagulopathy, history of more than one previous PPH. This history of PPH, either in the patient or in the family, is important. Hematocrit less than 30, that's an anemic patient with other risk factors, and thrombocytopenia with other risk factors. So these would be the high risk factors in patients who will make the patient prone to PPH. As far as this placenta accreta and placenta previa is concerned, I must offer a word of advice. Most of the times in our, and some of the times in our enthusiasm and in our efforts to do good for the patient, though your intentions may be good, you take up these patients in setups in which they ought not to be taken up for surgery. So small clinics with no backup support, no blood bank support, I think we must not be taking these patients and referring them to an appropriate place where such services are available. So saying no is important. And it is also important to say no even when you have opened the patient and realized that there is percreta on table. Because there is no point crying over spilled milk, and if some mishap happens, you will be blamed. So it is better that you just close the abdomen, nothing is going to happen immediately, and move the patient to a higher center. Active management of third stage of labor. Everybody of us has learned it as undergraduate students, as postgraduate students as well. So it encompasses administration of uterotonic drug within a minute of delivery of the baby. The drug of choice is oxytocin. So less than 1 minute of delivery of the baby, 5 units of oxytocin are given intravenously as a bolus, or 10 units are given as an intramuscular injection, or 10 units are put in 500 ml of normal saline, and it is run fast. Then followed by controlled cord traction, followed by uterine massage after the placenta is out. So the facility has to be prepared for this. Everybody should know their role, and it should be a teamwork. So who gives the injection, who tells when to give, who gives uterine massage, all these duties should be defined. It is good if you can, run your staff through the drill and ask them to do certain tasks at certain points of time, and sort of have teams and, create a competitive atmosphere so that they learn and actually practice what you want them to. Comparison of expectant versus versus the active management here. So in expectant management, uterotonics are not given. We are giving it in active management. That's the keystone. Signs of placental separation, you wait for placental separation, whereas in active management, you don't wait. You do the controlled cord traction by placing your hand suprapubically, feeling the uterus all the time, because you're not supposed to invert the uterus or you're not supposed to break the cord. So it's a tricky situation, and I think that's the most skillful thing in controlled cord traction and delivery of active management. So that is something that the obstetrician or the senior most person should be doing. Delivery of the placenta is delivered with gravity and assisted by maternal efforts usually, but here we are delivering by controlled cord traction by applying counter traction to the uterus. And we massage the uterus after the placenta is delivered. which decreases the third stage. Length of the third stage decreases the likelihood of prolonged third stage. It decreases the average blood loss, so chances of BT also, blood transfusion decrease, and it decreases the number of PPH cases and associated morbidity and mortality. Pharmacotherapy, of course, there are three classes of drugs: oxytocin and its analogs, oxytocin and carbetocin, ergot alkaloids, ergonovin, methyl ergonovin, that's methyl ergometrin, prostaglandins such as carboprost and bisoprostol. I must be very, very thankful to these drugs. These drugs have made our life easier. Otherwise, it would have been almost a daily nightmare to be practicing obstetrics. But these newer drugs have actually helped us a lot. This is early detection of PPH by visual estimation. I don't think I need to go through this. There are covers, labor table covers, which can measure the blood loss also. But we all know that accuracy is practically impossible. Causes of PPH, 4 T's, we already have seen this: prone, trauma, tissue, thrombin, and uterine atony is the most common. So when you rush to the scene, the first thing is that look at the uterus. If it is relaxed and flabby, it is atonic, you start giving massage. So if the uterus is contracted and there is bleeding, you have to explore and look for trauma or watch for DIC. If placental bits are retained, check the placenta for completeness. If the bits have been retained, you have to do the needful to remove that tissue. If you cannot palpate the fundus of the uterus, then it is probably uterine inversion, and you have to act quick and fast, because the patient can rapidly go in shock even without blood loss, because it's a vasovagal type of shock. The ovarian ligaments get pulled in, and that causes vasovagal shock. So you have to act quick and fast. And if it is DIC, you have to act quick and fast again. I think we've mentioned these uterotonic agents. Yeah, here is the controlled cord traction method, exactly how it is to be done. Examining the placenta for its completeness on both the surfaces is very, very important. You can ask, if you are not around, you can ask your staff to take photographs and send you on WhatsApp. That will do. Bimanual compression is done something like this. So imagine if the bladder were full, this will not work. So this picture is, the image should have a catheter in situ actually in the bladder, but let us presume that it is there. So uterine massage has to be given, and the uterus contracts with massage and can relax again. So one has to be wary of that. Yeah, here is a pictorial depiction of what to do if there is uterine inversion. So you hold the uterus nice and proper, and you try and push it in immediately. This can only be done if you are on the scene, because later on, the cervix contracts and the inverted uterus remains out of the vagina, and then it has to be done under anesthesia. Under anesthesia also, the patient has to be very deep, muscle relaxants are required, and then you try and reposit the uterus with the fundus being reposited the last. So first it is the cervix which gets corrected from an inverted position. Then it is the lower segment, and then the fundus, the body and the fundus which you're holding. Now, the patient who is not bleeding will start bleeding once the uterus is reposited. Most of the time they don't bleed because the vessels are all contracted. They're all, held by the cervical ring. So they don't usually bleed. But once you reposit the uterus, they may start bleeding again. And we have to be careful about that. Sometimes the placenta is in situ. So it is better not to separate the placenta and try and reposit the uterus with the placenta. It is difficult. And sometimes the placenta is adherent. So the moment you try and separate the placenta, that creates a problem. So one has to judge the situation and then take a call on this. This is Pannikar's and Samartharam suction cannula for PPH management. And this helps, and this works. It's a very useful device. So also these balloons most of us have them in our labor rooms nowadays, just as a backup. And you have to fill it up with 300 to 500 cc of normal saline. If you're doing it on table, if you have to fill it up because the patient is bleeding, then you fill it up partially, close the uterus, and then complete the fill and check if the remains intact. Aftercare, of course, oxytocin need to be continued, antibiotics, prophylactic antibiotics, blood transfusion as appropriate. And the balloon can be deflated over time or can be kept for around 2 days or so. And patient needs to be monitored, of course. Now, PPH at different levels, but since we are talking about resource poor settings, we should restrict to the first category. So wherein we have nurses, midwives, and a clinical officer, and 24 hours delivery possible, point of care, hemoglobin. These are all the facilities. These are the only facilities that we have. So we have to use judiciously oxytocin and other uterotonics, bimanual compression, aortic compression, which is again very, very useful. Aortic compression, manual removal of placenta, and repair of tears. That can be done with this. Finer care bundles for postpartum hemorrhage. So the first response PPH bundle is what we saw: uterotonic drugs, crystalloids, tranexamic acid, and uterine massage. WHO as the first drug to be given in a patient who is bleeding. So when you start that IV line, in one of the IV lines, you can put tranexamic acid 2 grams, and the other IV line can be used to add pitocin and such other uterotonics. And if there's still refractory bleeding, the patient does not respond, you have to take appropriate measures later on. Maybe a balloon tamponade or whatever is possible at your stage. Yeah, these are various stages of severity of PPH and the shock that happens. I don't think we need to go through this. Symptoms and signs of shock: tachycardia, tachypnea, hypotension, hypothermia, altered sensorium. Though this is not important for us, it is important for our staff. So this shows that tachycardia is defined as pulse more than 110. But for all practical purposes, for my staff, I teach them that it is a pulse more than 100 and BP less than 100, you inform me. That is the instruction, and that helped me all these years. So anyway, I think this is what I told you to begin with. The initial management of shock due to PPH is to call for help, evaluate, establish IV lines, start rapid infusion, give oxytocin, head-low position, lithotomy, and so many other things. So the first poem that I recited, that actually has most of it. Now, if you are fortunate to have an anesthesiologist on the scene, then things become easier and you can do your job, and the anesthesiologist takes care of the shock, administration of various drugs, monitoring the patient's pulse, BP, maintaining the airway, BP, and such other things. Whereas you can go on and explore the patient, put in a proper catheter, put in sutures when required, and give massage and watch for PV bleeding, if at all it's worse. If all this doesn't help, then we have to take the step of going ahead with surgery, wherein we do serial ligation of various arteries that supply the uterus. So you ligate the tubovarian vascular segment, the uterine, and if need be, the internal iliac also. And if this also fails, you are left with nothing else but to do an obstetric hysterectomy immediately. If you are working at a higher center, you have chances of using embolization or such other modern technologies. So in summary, it is PPH that is should be bothering Indian obstetricians the most. It is bothering the Indian obstetricians the most. And we've been doing our best to get over this problem. Community initiative, health workers, traditional birth attendants, they all should be taught early diagnosis and early steps that can be taken. our staff should be drugs should be used and despite formed at clinic and district hospital level to prevent and treat PPH. So it all depends on how expert your team is and how exposed your team is to these various vagaries of PPH and human pathology. Thank you so much. Thank you so much, Dr. Sneha, once again for having given me this chance to be here this evening. With this, I conclude my presentation. Thank you.
Thank you, Shantanu sir, for giving brief and detailed explanation and multiple intervention for PPH. And the poem was first class. Everyone should use that poem in your OT labor room for PPH. I want to add 2 points. Use shock index for every PPH case. Shock index is pulse divided by the systolic blood pressure. If it is more than one, as sir told, 100 pulse, 100 BP, you have to refer and use 4R during the PPH: readiness, recognition, response, and reporting. And actually, PPH bundles means multiple intervention at multiple point is a PPH bundle. So, sir explained all very detailed multiple intervention at multiple points. Thank you, Shantanu sir.
Thank you.
Kole sir, for your comments, please.
Yeah, thank you, madam, for giving me an opportunity to chair this session. Actually, I was a bit late. And thank you, Shantanu sir, for this wonderful insight into postpartum hemorrhage, one of the leading cause of maternal death. Actually, PPH, for prevention of PPH, we must start in ANC itself, maintaining patients' hemogram properly and taking care of the factors which will add to the problem. And once PPH, the abbreviation was used as a metaphor for panic hysterectomy, but with the advent of new uterotonics and all the better understanding of the subject, now we can very well avoid this, and we can salvage the uterus and by using all those methodologies, massage, then maintaining hemodynamics and giving uterotonics, we can come out triumphant. So thank you, Shantanu sir, once again for this wonderful talk.
Is Dr. Keval there?
Yes, ma'am.
Yes. Sir, for your comments.
Wonderfully explained by Dr. Shantanu Abhankar sir in managing the PPH case at the periphery center as well. Well-informed points about the primary health workers who initially manage the case of delivery or a cesarean section at periphery until the tertiary health center, where the management becomes very crucial. So very well informed by Dr. Shantanu Abhankar sir, and I thank everyone for giving me the opportunity as well. Thank you.
Sneha ma'am?
Yes, Shantanu, first of all, I must thank you. In spite of, last moment invitation, you could manage. I'm very happy to have you once again and in good health right now. So recently I have delivered the talk on the PPH in low resource setting at Mumbai, Amogs. And of course, there was a question here that what is the role of carbetocin? How do you rate it? Carbetocin, I think from all of our experience, it has mainly its role in the prophylaxis. Whenever you can predict, you should use it at the earliest. And prostaglandins is mainly for therapeutic purpose, never to be used for prophylaxis. That is what the practical tips also I want to give from my side. So thank you. And once again, over to you, Monica, for the second talk.
Yes, ma'am. Thank you, Sheetal sir.
Dr. P.K. Shah sir. And definitely I would request Monica to introduce the chairperson and introduce sir also.
Yes, sir. Thank you, Sheetal sir, Keval sir, and Kiran sir for chairing the session. Shantanu sir, thank you so much for an enlightening talk. And we now move forward to a very important talk on shoulder dystocia by none other than Dr. P.K. Shah sir himself, the teacher of teachers. I welcome the chairpersons for this session, Dr. Suman Kulkarni sir. He is currently the president of the Satara OBGY Society. Sorry, sir, ma'am, Sangli OBGY Society. Sorry, ma'am. He has been awarded the Young Talent Award, and he has undergone various trainings at places. He has many publications to his name in Amogs and AICOG, and he has been practicing consultant at the Swanand Nursing Home. We welcome you, sir.
Thank you.
Our next chairperson for today's session is Dr. Pradeep Dorle, sir. He is a consultant at the Sanjay Gandhi Government Hospital, New Delhi, and the Saurabh Hospital, Suraj, as a consultant. And he has been practicing in Miraj since 2012. He also holds a fellowship in laparoscopy at the Radhe Hospital and is trained under Dr. Mehul Sukhadia, sir. We welcome you, sir. Our next chairperson is Dr. Vilas Vartare, sir. He is the president of the Satara OBGY Society with 30 years of experience in OBGY. His special interests include high-risk pregnancy and innovative technologies in OBGY. We welcome all of you and we request you to please introduce our speaker for today, Dr. P.K. Shah, sir. Suman, sir?
Yeah. A very good evening to all of you. Am I audible now?
Yes, sir.
Yes. Thank you very much, Dr. Sneha Bhuiar, ma'am, to give a good opportunity for me, my secretary, and so many of our society members to participate in this live webinar. Thank you, Kiran, also for reminding me for arranging the zonal conference. We are trying on that also. And thank you very much. Now, today's topic, which is shoulder dystocia, actually, it is the most anxiety-provoking emergencies which is encountered by physicians who are practicing the maternity care. Shoulder dystocia is actually a complication that occurs after delivery of the vertex which has taken place, and when either the anterior and less commonly the posterior shoulder, it impacts on the maternal symphysis or sacropromontory respectively. Now, in today's modern obstetrics, because of the antenatal examination, estimation of the fetal weight on sonography, and maternal pelvic assessment, as well as predicting gestational diabetes and fetal macrosomia, we can take early decisions of posting the patient for cesarean section. But many times, the shoulder dystocia can be a sudden surprise to the practicing obstetrician, even for a normal size weight of the baby with small pelvis. Now, today's speaker, Dr. P.K. Shah, I think the sir needs no introduction at all. He is the teacher of teachers he was the professor at various medical colleges, the LTA Medical College, GS Medical College and Hospital, Parel. He has so many publications to his name and so many awards, a list is unending. He has Lifetime Achievement Award by Foxy in 2024, Lifetime Achievement Award by Mumbai Breastfeeding Promotion in 2014, first recipient of Young Gynecologist Award of Asia Oceania Federation of Obstetrics and Gynecology, Masters Award by Images in 2007, and so on and so forth. But more importantly, to say you, sir, that we have attended your lecture when you visited our society in the year 1996, when you might be remembering that, when Dr. Balasaheb Chopade was our president, and his institute was recognized for CPS DGO. And there you were invited to give a talk on breech presentation. And we, all the members, have attended your lecture. It was so fantastic. The lecture started at around 9:30 to 10 o'clock, and it was a marathon 3.5 to 4 hours lecture. Sir, I remember the way you have demonstrated the breech presentation, how to approach the breech extraction, and nuclear displace hands after coming head on your own body, that I still remember it. In today's world, when we are getting the breech presentations, we people normally post the patients for sections. It is hardly when the patient comes late in labor with breech on perineum. And when we conduct that, sir, I remember your lecture definitely. Thank you, sir. Thank you so much.
Thank you. Can I share my? Okay.
We can see your screen, sir. Yes. Slideshow. Yeah.
Okay. Thank you, Dr. Sumant, for my introduction and remembering way back what I talked in 1996 on breech. Let's do it again, but of course, we have a time limit. At the outset, let me apologize for joining late. I was in one more webinar, and I don't know, Sneha, I'm not contesting for any post, but this is my fourth webinar today from
Right.
4 o'clock.
That shows how popular you are, sir.
No, I don't know, but I think last day of February, everybody wanted to squeeze me, and that's the reason this is the fourth webinar. So I'm not worried about time. Let me thank Amogs and office bearers, Dr. Kiran Kurtakoti, Dr. Rajendra Singh Pardesi, Dr. Bipin Pandit, Dr. Madhuri, and of course, Dr. Sneha Buyar, who is the chairperson of Amogs Emergency Obstetric Committee. She was a past chairman of medical disorders, I think, committee, and of course, breastfeeding committee of Foxy. Now, shoulder dystocia is something which all of us have to deal with. You can't run away. So let's see how we don't get stuck with shoulder dystocia. And my topic involves definition, incidence, consequences, risk factors, and management. What is the definition? That a head to body delivery time more than 60 seconds due to impaction of the shoulder, usually anterior against the symphysis pubis, as the definition has been given by Williams Obstetrics. The mean time of normal delivery between head and body is around 24 seconds. And when it goes beyond 79, well, you know it is shoulder dystocia. Unpredictable obstetric complication, the incidence is 0.15 to 2%. There is an increase in the incidence of shoulder dystocia over the last 20 years, and incidence appears to be increasing as the birth weight increases. As you can see here, birth weight between 2.5 to 4 kg, 0.2% incidence. Between 4 to 4.5 kg, 1.7%. And if the birth weight estimated is more than 4.5 kg, it is 10%. Now there is something like bilateral shoulder dystocia, whereby you have a bilateral shoulder dystocia. The posterior shoulder is in the hollow of the, is not in the hollow of the perineum. And this presentation often requires a cephalic replacement. This is the commonest, whereby you have a unilateral shoulder dystocia, usually dealt with by us in a standard way. And it is the anterior shoulder which is stuck above the pubic symphysis. Now, how to recognize that there is a shoulder dystocia? That the head appears at the introitus and then it retracts back in the birth canal, which is typically called turtle sign. Delivery of head with arrest of shoulder delivery, usual maneuvers, it fails, and there is a minimal downward traction that doesn't affect the delivery. You try to do it, it will not deliver the way normally we deliver. So what are the risk factors? Remember, many cases of shoulder dystocia occur with no readily identified risk factors, but there are some antepartum risk factors like maternal obesity, diabetes mellitus, postpartum pregnancy, excessive weight gain, short stature, inadequate pelvis, prolonged second stage of labor, induction with oxytocin, and mid-forceps and vacuum extractions. Fetal macrosomia and maternal diabetes are most strongly associated with shoulder dystocia. There is no single risk factor or combination of risk factors are predictive for which infants will experience shoulder dystocia, as shown by American College of Obstetrics and Gynecology. Now, obviously, you are worried about fetal complications like fetal fractures, 18 to 25%, Erb's palsy, although 80% will resolve by 18 months. Perinatal asphyxia is uncommon, brachial plexus injury is quite common, and neonatal death, which is very rare. Now, why does the brachial plexus injury occur? Basically, because of downward traction on the neck when we are trying to deliver the head. Most important fetal effect, most common cause for litigation in shoulder dystocia. Please remember this. Independent of operator experience. The good news is 80% of cases of brachial plexus resolve in 6 to 13 months. Maternal complications include postpartum hemorrhage, vaginal lacerations, cervical lacerations, puerperal infection, and extension of episiotomy. Can it be prevented? The answer is no. But there is room for prediction and anticipation, as has been told to you by Dr. Suman Kulkarni, that you know that ultrasonography can be used to diagnose macrosomia and also the clinical assessment plus ultrasonography to assess the pelvis. How do you prevent shoulder dystocia? Prevention of shoulder dystocia with cesarean section prior to labor should only be considered under unusual circumstances, like estimated fetal weight in diabetics more than 4.25 kg, estimated fetal weight in non-diabetic of more than 5 kg, and prior history of shoulder dystocia with injury to infant in the form of brachial plexus palsy, limb fracture, asphyxia, etc. 50% of shoulder dystocia cases occur with average weight. Please remember that. That is less than 4 kg. So always be ready because it is unpredictable and unpreventable. Once recognized, what you should not do not ask the patient to push, do not apply fundal pressure at all, and do not panic. And think of HELPERR, helper. Management includes preparation, which means educate and involve the patient ahead of delivery, declutter the labor room, senior most obstetrician should be available, empty the bladder, stay calm, and again, helper. Individuals who must be present in the room if shoulder dystocia is anticipated or encountered include physician, then obstetrician, senior most, anesthesiologist, pediatrician or neonatologist, obviously nursing staff and extra hands. Avoid 4 P's, panic, pulling on the head, pushing the fundus, and pivoting the head. There are 4 grades. Mild, you can do Mac-Roberts maneuver, that is suprapubic pressure. Moderate, you can have Rubin's maneuver or Woods or reverse Woods maneuver, especially for posterior shoulder. If it is severe, you can do fracture of clavicle and humerus, or undeliverable, do cephalic replacement and abdominal delivery. There are so many names when you talk about shoulder dystocia. When we were residents and even students, it was very difficult to remember all these names. Like Mac-Roberts maneuver, suprapubic pressure, Gaskin's maneuver, Woods maneuver, Rubin's maneuver, delivery of posterior shoulder, Zavanelli's maneuver, symphysiotomy, and some more which I'll tell you. What are the preliminary steps? Call for help and have the team assembled. Drain the bladder. Perform generous episiotomy. Take your own time. This is an emergency, but it's not a race. Please remember this. Don't injure the baby in trying to deliver her fast. So what is this HELPERR? Call for help. Evaluate for episiotomy. For legs, use Roberts maneuver. P for external pressure suprapubic. E for enter rotational maneuvers. R for remove the posterior arm. And again, one more R for roll the patient to her hands and knees. So that is what HELPERR means. Now, each step should not take more than 60 seconds. And totally, with all the maneuvers that you might have to do, should not take more than 5 minutes. Better if you take within 3 minutes to deliver the head. No indication that any of these maneuvers is superior. They represent a valuable tool to help clinicians take effective steps to relieve impacted shoulder. Call for help. You must have shoulder dystocia drill to see that the team works well, and you must do documentation. E for episiotomy, evaluate for it. May not be for all cases, but ideally, if you ask me, if you are going to do the maneuvers, you will have to give episiotomy, obviously, before delivery of the shoulders. When you want to manage legs, it is a Mac-Roberts maneuver, which is safe, simple, and effective, and used alone resolves 40% of shoulder dystocia. Remove the bottom of the bed, place the back flat of the patient, and lift the knees to the chest, which is something very simple. Mac-Roberts position, and evaluate for an episiotomy. So this is before positioning, and then you bring the legs towards the chest is Mac-Roberts position. What happens when you do this? That it straightens the sacrum, moves the symphysis pubis towards maternal head, and frees the impacted shoulder. Something very simple that anyone can do. Then P for suprapubic pressure. Determine the position of the fetal back. Initially, you can give continuous suprapubic pressure, and then just like in CPR, in rocking motion. This is how you have to do the suprapubic pressure when somebody is trying to deliver the head. E is for enter internal maneuvers like Rubin's and Wood's screw maneuver. So what is Wood's corkscrew maneuver? The shoulder must be rotated. Utilize the pressure on the scapula and clavicle. Your thumb should be on clavicle and 4 fingers on the scapula. Do not try to rotate the head. Please remember this very clearly. It has to be shoulder. And this is how you put your fingers inside. 1 thumb on the clavicle and 4 fingers on the scapula, and you rotate so that from anteroposterior, the sacromial diameter, you bring it in the oblique, which is any time bigger than the obstetric conjugate. So that is a Wood's screw method. Rotate the posterior shoulder by 180 degrees. If it is the anterior shoulder, push it from behind. If it is the posterior shoulder, push it from front of the shoulder. What is Rubin's one? That rocking the fetus shoulder from side to side. So you rock it and try and see if it can be delivered. Then there is something called as a, now if it fails, you go for reverse Wood screw. That posterior shoulder should be moved to anterior, and that is how we will be able to deliver it very easily in a screw fashion. R is meant for remove the posterior arm. So deliver the posterior arm so that you have more space available to deliver the baby. To bring the fetal wrist within the reach and exert pressure with the index finger in antecubital junction so that the fingers of the baby are accessible to your hand, and then draw it over the chest and deliver it. The next R is meant for roll the patient. In knee, this is how you will have all the 4 limbs touching the ground. And this is called as Gaskins maneuver. How does it work? It might be disorienting for some unfamiliar doctor, but it increases the obstetric conjugate by 1.5 centimeters. Gravity may help, or the movement into this particular position may help. The same maneuver can be applied for delivery of the head as discussed earlier on. This is Mazenti's technique, whereby you try and push the anterior shoulder away by 45 degrees into the oblique diameter. This is done totally abdominally. Please remember this. And that is Mazenti's technique. If all fails, as last resort, do deliberate fracture of clavicle. It's very easy. If you've done it even once in your lifetime, you will find it very easy. And there is something called as Zavanelli's maneuver, whereby you give tocolysis to the mother, replace the head into pelvis, and go ahead and do C-section. Symphysiotomy, there is a risk of urinary tract or spinal injury. You can do cleidotomy if there is a dead fetus, and then abdominal surgery and hysterotomy. Cleidotomy, the anterior clavicle is pressed against the ramus of the pubis. Care should be taken to avoid puncturing the lung by angling the fracture anteriorly. Theoretically, a fracture of the clavicle is less serious than a brachial nerve injury and often heals rapidly. What about symphysiotomy? It's just cutting the symphysis pubis in the center. Should know about it. Once in lifetime, it may be needed. Now, this Zavanelli's maneuver was first described in 1988, consists of cephalic replacement and C-section. Now, a very important question, can C-section for suspected macrosomia reduce the rates of shoulder dystocia? Answer is no. Sensitivity of clinical estimates of birth weight more than 4.5 kg is only 20%. And ultrasonography is not very accurate at extremes of estimated fetal weight. Most cases of shoulder dystocia occur in infants of average weight. Please remember this. And the incidence of birth trauma in large infants is not trivial, almost 2.5% with birth weight more than 4.5 kg. So, to give you take-home message, ladies and gentlemen, shoulder dystocia is unpredictable, and most of these cases occur in patients with no risk factors. Always be ready and calm while dealing with the shoulder dystocia. Know your HELPERR. Permanent fetal injury may be prevented by limiting non-axial traction on the fetal head. And a mock drill in labor rooms proved to be helpful in a need of action. What is important is documentation and debriefing after shoulder dystocia, essential part of good patient care. Thank you very much, ladies and gentlemen, for patient hearing.
I think the chairpersons can make the comments.
Requesting Suman sir to give the concluding remarks, please.
It was really a wonderful lecture by Dr.
Pradeep
P.K.
sir?
Shah, sir. As usual, am I audible?
Yeah.
It was a wonderful lecture, sir, as usual.
Thank you.
The various types of maneuvers which we have explained very well, one has to keep in mind. There is no ideal manipulation or treatment exists for shoulder dystocia as such. But all the maneuvers which we are doing to get relief of the shoulder dystocia, I think they do 3 important steps. The one is enlarging the maternal pelvis. because of the cephalite rotation of the symphysis and flattening the sacrum so that roominess of the pelvis would be increased. The second is to collapse the fetal shoulders, that is to reduce the bisacromial diameter by giving the suprapubic pressure. And third, by rollover method, which sir has already explained, we're altering the orientation of a longitudinal axis of the fetus to the plane of the obstruction. Ideally, today's both the topics, the shoulder dystocia and the second is postpartum hemorrhage, are threatening to every obstetrician. Whenever I go to a labor room and conducting a delivery, I always pray that there should be no shoulder dystocia and no PPH. Thank you, sir. Thank you for a wonderful presentation.
Thank you.
Pradeep, sir?
Okay, I would like to first of all thank Sneha Buyar madam for giving me an opportunity to chair this session. And thank you, Shah sir, for such a wonderful lecture, as shoulder dystocia does present some significant challenges in our practice. After listening to you, there is no more comments are required for this. Thank you, sir.
Thank you.
Yes, Monica.
Miraj sir is there for sir's comments. I can't see him, ma'am, actually.
No.
Ma'am, for your concluding remarks.
No, after sir's talk, there is no concluding remarks, sir. We just take his blessings and go ahead.
I must say one thing, that some of my slides, which I used to use when I was a teacher at KM in Science, have been modified with Sneha's slides, to be honest. And I wish Sneha all the very best for her vice president's post in Foxy. Wish you all the success and growth in future. Thank you, Sneha.
Thank you so much, sir. In
Being
fact,
a part of this webinar.
Thank you so much for your blessings always, sir. We missed you at inauguration. It was indeed a very emotional moment for me. This is the first virtual program of my new committee.
Oh, wow.
New assignment.
Congratulations.
So,
Congrats.
Thank you, sir. Thank you so much once again. Over to you, Monica.
Thank you so much, sir, for joining us today and with an exhaustive and elaborate talk on shoulder dystocia, a need of the hour which almost all the junior obstetricians today might not even be aware of. Thank you so much for being an able guide to all of them. I am sure they must have taken a very good take-home message from your talk. Let us move forward for the session on panel discussion on near-miss cases by none other than our moderator, Dr. Sneha Buyar, madam. Madam has already been introduced, so I will quickly introduce all the panelists first. Dr. Ravi is currently working as an associate professor and HOD at the Department of Government Medical College, Miraj. The next slide, please. Dr. Monica, madam, is the past president of... one second, ma'am.
Miraj Sangli.
Yeah, Miraj and Sangli Society. She has done various courses, including the ultrasound and the pelviscopy trainings from Germany. She has many research and publications to her help. She has been the president of the at the RC Vishrambagh, the assistant governor of the Rotary District, the Miraj OBGY Society, the IMA Clinical Secretary, and Rotary Vishrambagh Trust Secretary from 2014 to 2017. She is also an internal auditor for NABH and PG in Quality Management of AHOs. We welcome you, ma'am. Dr. Kanchan Joshi is a practicing gynecologist at Sangli since 2008, and she's currently the Amogs Youth Coordinator. We welcome you, ma'am. Dr. Surya Kumar Khandare, sir, is a consultant at Aryavidi Hospital at
Satara.
He's also a consultant, State Executive Committee, IMA, the president of the IMA Satara branch 2022, and an executive committee member on various clinical and research team Foxy, the Amogs High Risk Pregnancy Committee, the Foxy HIV Committee, and the Amogs Aesthetic and Sexual Medicine Committee. We welcome you, sir. Our next panelist is none other than Dr. Varsha Lahade, madam. She has been the past president of the Nashik OBGY Society, and she was the organizing chairperson of the Amogs held at Nashik. She is also the zonal coordinator at Amogs.
Okay, you can go
We welcome you, ma'am.
Thank you.
Our next panelist for today is Dr. Reshma Rajbhai, ma'am. She is a consultant at the Sai Amrut Multispeciality Hospital, and she's been on board at various posts in the society at Satara. She's also the assistant professor at Nandadeep Hospital and Research Center. Our next chairperson, panelist for today is Dr. Vikas Devkare, sir. He's an associate professor at GMC Miraj, the unit head and postgraduate teacher. He has his active participation in IAG in Foxy, and he has been freelancing for obstetric emergencies in and around Konkan and Satara areas. We welcome you, sir. May I request Sneha Bhuyar, madam, to please conduct the panel discussion for today.
Yes. Very good evening once again to all of you. And I'm sure all of you are enriched with the two most dreaded complications of obstetrics. I would say the shoulder dystocia and postpartum hemorrhage. I'm sure definitely somewhere it will be useful for you, all of you, in your day-to-day practice. I just take this opportunity to thank everybody, and without much ado, I start my panel discussion. I welcome all of you. You have been introduced, and I would just say that whenever we are moderating this, panel discussion, or whenever we are discussing this about maternal mortality, it's also called as the severe morbidity by WHO, and we are always talking about maternal mortality rates and ratios. So friends, I would just say that these are not just the numbers and figures. These are women whose faces we have seen, the faces of their agony, distress, and despair. And these keep on haunting your dreams. That is how it has been expressed by Dr. Mohammed Patala, who is the past president of FICO. And similarly, Ian Donald, who has also expressed that looking back over the clinical times, one tend to forget the failures, and it's only the success which is taken for granted. So these are the failures which stand out like keloids, never to be forgotten for the person who has suffered it, and hopefully warning for the others. So as I have already said, that it is, near miss. So this terminology we have borrowed from the airlines industry, and it tells you the gravity of the situation and the urgency of intervention it is needed. So without much ado, I would start with this quote that life is the best teacher, and we never stop learning because life never stops teaching us. So friends, every case is a new lesson for all of us. So with this, we start with the first case itself. And this is just a warming up case, I would say, with minimal discussion. We have this second gravida, previous cesarean section. She's got a 1.5-year-old live child, and she comes to you with 7 days overdue. You do have urine pregnancy test that comes positive. She's asking you for medical abortion. You prescribe the tablets. You give her necessary information, and you ask her to come for follow-up after 7 days. I wouldn't say fine day, but a bad night. She comes to you at around 11 to 12 midnight in a collapsed condition. She's brought to you by the relatives. So Dr. Ravi Rawal, I would like to ask you, what is your diagnosis or differential diagnosis at this point of time, and how would you manage this patient?
Ma'am, sir is busy in an emergency, so he will join in some time, ma'am. That's what he messages me right now.
The next panelist can take up this. Dr. Vivek.
Should I take this?
Anybody, please.
My differential diagnosis in this case is this can be ultrasound is not done, so this can be scar ectopic, this can be ectopic pregnancy, or this can be incomplete abortion. So immediate ultrasound and resuscitating her from her condition of shock is very important. Means we have to arrange issue blood for.
I would just interrupt you here. If you had seen the history, it's only history of spotting and giddiness. So the incomplete abortion, causing shock, it should have at least the, excessive blood loss. So I think we rule out incomplete abortion here. So what remains is scar ectopic and the ectopic pregnancy for that matter. So how would you go ahead with the investigation? The late hours of night, you are in a small place, whether you have ultrasound, bedside ultrasound can be done. So bedside investigations, whatever could be done, hemoglobin was 7 gram%, and somehow it was could be managed, the ultrasound. It is showing adnexal mass with free fluid in pouch of Douglas. Now, what is your diagnosis and how would you proceed?
This is clear-cut ectopic pregnancy. So better to issue blood, call the anesthetist, start blood, and go for the laparotomy or laparoscopy. And
what
we
about
have
talking to the patient and relatives?
Yeah, we have to take the consent.
We have to explain them basically what is the diagnosis, that you have to explain to the relatives why it has happened, because she has taken the medical the pills from you. So naturally they will ask you, doctor, why this has happened. So how would you counsel the relatives? That is the first question. Then I would ask you how would you manage this case? And then the third question is, of course, how you could have prevented this.
Yeah, first and foremost and difficult thing is to counsel the relatives, but it is an emergency, so we have to counsel them that this is ectopic and it is seen in the ultrasound, and we have to go for a laparotomy. And after written informed consent and issuing blood and getting anesthetist, we have to proceed.
Okay, so you have done everything. You have tried to manage the patient, and you could save the patient, operate her well. Maybe during procedures, yes, you do have, whether you laparotomy or laparoscopy. That is one more question I would like to ask you. She's a case of ruptured ectopic pregnancy, whether you want to go for laparotomy or laparoscopy.
For me, laparotomy is an easy option, but for others, it can be laparoscopy also.
Yes. So whenever you have a good gynec endoscopic surgeon or who is well versed with this procedure, even in fact, there are endoscopic surgeons who will catch hold of the bleeders at the earliest in spite of so much of bleeding, and they can proceed for the definitive surgery at the earliest. So even previously we had that concept that because it's a ruptured ectopic, you should go for open procedure, that is laparotomy. So that doesn't hold true nowadays. That is one. Whether you would go for conservative surgery or the salpingectomy.
That will be interim decision, but it is a rupture ectopic, so better to go for salpingectomy rather than salpingostomy.
Yes, because basically the very fact that she has developed ectopic pregnancy, that means there is some problem, some damage with the fallopian tube, and that is why she has landed up into ectopic pregnancy. Now that this patient has got ruptured ectopic, definitely you have to go for a salpingectomy. Okay. So now the question.
Madam, may I interrupt for a moment?
Yes, Shantanu, please.
Yeah.
We're coming to the preventive aspect, but before that, if you want to say something.
Yeah.
Please.
In the differential diagnosis, one must also consider heterotropic ectopic gestation in these patients, because patient has had a sudden intra-abdominal bleed. That is what it means. So it could be that there is an intrauterine pregnancy as well as an ectopic pregnancy which is given way. So heterotropic pregnancy should be kept in mind. And
yeah, that is right. But Shantanu, the whatever situation she has come to you with because of ruptured ectopic. So intrauterine pregnancy.
Yeah, so this is the heterotropic pregnancy that has ruptured, and the intrauterine pregnancy probably has aborted, or we don't know what happens. We have to do an ultrasound.
I think on the ectopic pregnancy, very well, as you said, yes, they can be heterotopic pregnancy, you are right, but because she is not bleeding externally, she has only history of spotting, so that abortion is not leading to this shock. It's only the ruptured ectopic that has led to her condition. Now the last question to you, Kanchan, whether you could have prevented this and what precautions the prescribing doctor should take it.
Prescribing doctors should always do ultrasound before prescribing pills. And if possible,
is it a mandatory investigation by law?
It's not mandatory, but
by law it is not mandatory, but we have to do, but because such situations we can predict, complications we can avoid.
Yes, and it is not mandatory, but it is recommended for the safety of the patient as well as yourself. Okay.
And before prescribing, we should also do CBC or finger prick HP, or at least we should see whether patient is pale or not.
We have to do the basic investigations, the CBC, blood group, and of course, the minimum necessary investigation. But ultrasound is mandatory, or I mean, it is recommended for the safety of you as a doctor and for the patient. But you have, it is not mandatory by law. That you have to remember. Okay, so this was just a warming up case. And now we go ahead with the second case. You have this 36-year, I think two of you, please stay tuned to this case. 36-year-old woman, she conceives after IUI. The husband is working in Dubai and this lady is staying in the village. So after 24 weeks, she's coming regularly for the NC checkup. She finds everything is fine. Now she goes back to the village. At around 34 weeks, she comes to you with severe pain in abdomen, comes to the PHC doctor, where he finds that she's got mild edema. Blood pressure is 176 by 116. Fetal growth is apparently normal according to him, and proteinuria. Her blood pressure was measured at PHC. It was high, so the medical officer gave tablet nifedipine retard. Okay. And the patient was advised and counseled for the possibility of early delivery, but the patient did not get admitted or did not go to the higher center. And after 2 days, she goes to the higher center, that is sub-district hospital, where she got admitted and her blood pressure as admission is 168 by 110. So again, the medical officer here also gave added tablet labetalol. And because the facilities were available, he has taken this patient for cesarean section. Caesar was done, baby is fine, but the patient's blood pressure was almost between 140 to 180 systolic and 100 to 110 diastolic, even on tablet nifedipine and labetalol. And then they started with Maxel because she had severe abdominal pain and headache. Okay, so on the next day, this patient landed up into sudden severe breathlessness, cough, restlessness. The pulse rate was high, BP was 220 by 118, and the oxygen saturation was 70%. So, Dr. Monica, what is your differential diagnosis for this patient? How will you come to the definitive diagnosis, and how will you manage this patient?
Yeah, good evening, everyone. Keeping in mind her past history of preeclampsia and almost unattended and untreated adequately in her antenatal time, she was taken for C-section on an emergency C-section and taken 30 hours post C-section. We can, I'm audible?
Yes, yes.
So my differential diagnosis here would be pulmonary edema and pulmonary embolism. Initially here I would like to explain, because it's 30 hours and this is the time when everybody would have relaxed, basically, that the tension and this the acuteness of the case has been passed off. So this is the time the patient comes with an emergency. So inform the patient relatives, counsel them regarding the seriousness of the situation, and shift her to the ICU, put her on a proper position, start high flow oxygen and recatheterize if the catheter has been removed, and immediately keeping in mind the pulmonary edema and the embolism, start heparin. I prefer unfractionated heparin as it is.
Monica, I would interrupt you here. You are suspecting pulmonary edema and the history is also going in favor of. So in addition to the proper position oxygenation, what is the first drug you want to give?
I would like to give her Lasix.
You will call for help. So naturally your anesthetist, physician or intensivist, they will all run for you.
Call for the physician, start Lasix. I would like to start Lasix. Reduce the edema first. 40 milligrams IV stat Lasix.
How much is the Lasix?
40 milligram IV stat, and then you start, start
minimum
IV.
40 milligram, because we obstetrician tend to give it 20 and even all those pediatric dosage. So strict no.
Start 40 milligram IV Lasix, and then on the infusion pump infusion pump you continue with the Lasix for the next 24 hours. And settle her, see that her oxygen saturation starts coming up, and at the same time, as her blood pressure is still very high,
full of wheeze, no clear breath
reps and wheeze.
But you would like to give something.
So once your high flow oxygen has been started,
wheeze, not creps. There are creps, but it is wheeze also. Some element of bronchospasm is also there.
Budicort nebulization you can start with to her with high flow oxygen. And once the saturation starts coming up and the chest starts clearing, you even look for as her blood pressure also, which is on the higher side. You need to bring that also down.
So what drug you will give? That is what?
IV Labet.
How much?
I would like to start IV Labet 100 milligram 6 hourly, or it
IV
is
labetalol. How do you give it? What is the regime? How do you start it? How much? IV labetalol, you start with 40 milligram. Anybody else want to take up this? Reshma, Varsha?
Yeah. This is a classical case of pulmonary edema.
Yes,
No
we are
doubt.
talking
There is no
about
other
labetalol,
differential
IV labetalol.
diagnosis for this patient. So first and foremost is injection Lasix, which is stat 80 milligram. It's a dose ideal for this pulmonary edema. High flow oxygen and other things, nebulization doesn't.
Yes, that she has said,
First
Varsha.
of all
We're
is
talking about Lasix.
Okay.
We're talking about the labetalol.
Labetalol injectable, you have to start 40 milligram intravenously. Monitor her blood pressure after every 5 minutes. And if it's not coming down, again, next 40 milligram. Maximum dose is 120 milligram.
Yes. So 40 milligram intravenously, wait for 10 minutes because that is the time required for the drugs to act. And then if there is no desired effect or lowering of blood pressure, you give for 80 milligram. If there is still no desired effect, you can repeat 80 milligram, maximum of 300 milligram. That is what. So this patient was, given all the management, what you have said, but she was already on the verge of going into cardiac arrest. So she developed cardiac arrest, and now your anesthetist and intensivists, they're giving CPR. They put her on ventilator and they could revive her. So after 1 hour, she had spontaneous respiration, everything. The blood pressure also comes back to 100/64. So, Dr. Kanchan, I would like to ask you, in this case, what went wrong and at which stage?
In this case, her proper antenatal follow-up was very essential. From first 3 months, we should see her uterine artery Doppler.
I would say, is it the follow-up or it is the right from prediction you have missed?
Yeah, we have to predict eclampsia, or we have to predict PIH in this patient. So for that, we can do screening test along with the anti-scan, along with the double marker. We can do screening test for her, or we should have noted at least uterine
What
artery
screening
Doppler.
test you want to do? What screening test you want to do? And what are the risk factors by the way, for this patient?
Yeah, first with uterine artery Doppler, we can start
What
her
are
on
the risk factors? What are the risk factors clinically?
Clinically, after 5 months, she developed pedal edema and everything.
She is 36-year-old, that is elderly gravida. She's a case of infertility conceived on ART. And of course, she is not very regular on her ANC checkup. Okay. So all these three are risk factors. But at first visit, she definitely elderly gravida and infertility. These are the two risk factors. Okay. Then, of course, you have to triage this patient. You have to, SDP gestosis score. That is what the most useful cost-effective measure. You can take it during early pregnancy itself. If you find the score is more than 3, then definitely you have some preventive measures, and that is low dose aspirin, that is 75 milligram, and high dose calcium vitamin D3. Okay.
Yeah.
Then you have certain biophysical and biochemical tests for prediction. Okay, in that what you are describing is uterine artery pulsatility index and the various biochemical tests, PLGF.
In biochemical test, we can do her PLGF.
Okay, yeah.
And after the first visit, when we noted her edema, and at that time her BP was also on higher side. That time she should have started on IV labetalol. Then that would have helped.
So I would interrupt you once again here. So for severe hypertension, right? She reported with 176/116. So we label this as that to upper abdominal pain. Okay. So she had all features of severe hypertension. So this is a time where you have to investigate the patient in detail. If not, it is done at that level of healthcare, you have to refer the patient to the higher center. That is what is missing here. If at all you have to give at PHC also, you cannot give injectable labetalol, but you can definitely give capsule dilfedepine 10 milligram, the orange color capsule, which, the onset of action is within first 5 to 10 minutes and the peak action is within half an hour. The duration is 6 hours. So you can have good control of blood pressure by the time you transfer the patient. Okay. So this is how you have managed the patient and she has recovered. But we have to take a lesson here that first and foremost, you have prediction in your hand. You have the preventive measures in your hand, early detection and prompt and appropriate treatment. Otherwise, the simple, routine ANC patient can, land up into all these complications. So we have to we have to introspect ourselves. So do we have Dr. Surya Kumar here?
Yes, madam.
Yes. So hello, Dr. Surya Kumar. We
Yes.
have this, 20-year-old young primary gravida who is coming to you with 9 months amenorrhea, and she's, she was admitted at some adjacent small nursing home. She was there in labor for around 8 hours or so, and at around 11 p.m. at night, she was referred to you. Why? Because she was not progressing, and when the sister catheterizes her bladder, there was no urine, and then they realized maybe since morning she has not passed urine. Okay, so that was almost the time of cesarean section. She was diagnosed to have anuria. So when you examine, you find there is tachycardia, blood pressure is 110/70, uterine contractions are very severe, not relaxing in between. The fetal heart is 100 to 120. And now the dilatation is 7 centimeter here. Membranes are absent. So what is your diagnosis for this patient clinically on your examination? And of course, there is some blood stain discharge.
Hello, madam, might be the case of arrest of the labor.
Arrest of the labor is yes, she is in prolonged obstructed labor, but she is having severe contraction. That is also a sign of mechanical obstruction, but she is having bleeding now, fresh bleeding she started. And when you do the investigations, you have hemoglobin 8 g/%, the platelet count is only 1 lakh, PT-INR is 2, and epitit is prolonged. The fibrinogen is only 150 and FTP is present. Fibrinogen degradation products.
We have to
Now
think
what
about
is your
the
diagnosis?
coagulopathy disorder.
Yes, because of what?
Because her PTINR and APTT is been prolonged.
Yes.
And there is presence of a fibrin degradation product.
Yes.
Fibrinogen agent. So we have to first think about the DIC or coagulopathic disorder in this case.
DIC, but because of what? Because
abruption.
Abruption or might be the uterine
Rupture or abruption?
The abruption.
Abruption.
Now you let me know how will you manage this? What are all aspects of this, this patient you have to manage? So you have labor to be managed. You have the obstructed labor. You have the one more thing I want to comment here that BP is 110/70. Are you happy with this?
No, if it is along with the this finding, it is might be having some sort of shock. We have to think in this case.
So we have to think that her BP might be high, because of which she has developed abruptio, and now her blood pressure is 110/70. Okay, so you have to manage all these aspects: hypoxia, hypovolemic shock, anuria, labor, and fetal distress, and then DIC, the coagulopathy. Okay, so how will you, whether you would do cesarean section first for fetal distress, or you will arrange the blood and blood product, wait for them? How will you?
First of all, we have to resuscitate this patient, and simultaneously we have to make the proper arrangement of the blood and blood component.
Correct.
We have to give the this Tranexa, Dexa in such cases. Primary vitamin K can given in a 30 milligram IV bolus. Then we have to inform all the inform the anesthetists. We have to take a proper consent from the relatives about all the high risk factor. Consent pertaining to might be landing up this case in a postpartum hemorrhage. And require a prolonged ICU admission and all other complication because of the related with this abruption.
Yes.
Then I will prefer to go for cesarean section after resuscitation of this case. and we so that we can able to save the baby and mother in this case.
Yes. Once again, I repeat the question. You have explained this very well. I fully agree with you. I repeat the same question. You will whether you will do the cesarean section first or you will wait for the blood and blood products.
First of all, I want to correct her the PT and this APDT by either we can
But
give.
by the time you will lose the fetus.
No, simultaneously we can give for cryoprecipitate in this case. No?
Yes. So I would say that everything has to be done simultaneously. The moment you feel that the blood bank is, getting ready with all these blood and blood products, you may just start resuscitating her and take her into OT. And by the time the blood and blood products should be ready. So I think you have to optimize everything, the maternal as well as fetal outcome. So this is just a theoretical. I'm not going to read this, the grades of Brabshaw, etc. I will just tell you about the blood and blood components. In this case, when the fibrinogen is 150, how would you manage this aspect? Anybody can take up. This is an open discussion now.
If we have to think about giving cryoprecipitate in this case and fresh frozen plasma.
Okay.
Usually in these cases might require the activation of massive transfusion protocol sometime. It can be given in a ratio of RBC to FFP to platelet in 1:1 ratio, or in few cases you can go in a 2:1:1 ratio.
Correct. You are very right, because the patients of FPH due to abruptio especially, these are the ones who are very prone for going into postpartum hemorrhage, because the covalent uterus and the DIC, all these factors together, they're very prone for PPH. So you have to explain the relatives that right up to, obstetric hysterectomy, maybe even the maternal death, you have to explain everything at admission, because unless you predict it, you will not be able to counsel the patient and relatives. And once you start managing, it will be very difficult for you to defend yourself and manage the patient, because your one team should be talking to the patient and to the patient's relatives. One team should be, coordinating with the blood and blood products. And then you should have the anesthetist, intensivist with you, so that you can go for cesarean section, and the neonatologist should be there ready to receive the baby. So I think the case is very well discussed. Now we come to you, Varsha. We have this 32-year-old para one previous one cesarean section. She has one-year-old male child, and she comes to you with bleeding PV. Okay. This is her first visit to you at 6 months because of the transfer of her husband's job. She was registered somewhere else. So that time during early pregnancy, she has had spotting, and her old USG report is showing, low-lying placenta. Now, this patient comes, when she comes to you with history of bleeding, you do her ultrasound. It is suggestive of placenta previa with absent retroplacental leg. Anomaly scan is normal. So this patient comes to you for follow-up at around 30 weeks. That is exactly after 1 month you have advised her to come for follow-up. She started bleeding at home significantly, but the moment she reaches the hospital, again it stops. And during investigation, she, started bleeding significantly and she collapsed. What is your complete diagnosis and how would you manage this patient?
Yeah,
Last question is again there, but that we will discuss later whether it could have been prevented.
Yeah, this is 32-year previous LSCS patient, placenta previa, and here she had a history of spotting with history of placenta previa and ultrasonography. That's not a history, like that's a USG finding. And thirdly, she had a bout of bleeding, and again now she has collapsed. So this is classical case of placenta previa. Here I should first of all, as I have Dr.
I would interrupt you
Shantanu
here, Varsha. Whether it is only placenta previa or something else.
Yeah, placenta previa is the
accreta also. So there's a retroplacental leg is
absent
absent.
retroplacental zone or leg, absent RP leg. That is diagnosed here.
Accreta also.
Okay.
Maybe the possibility of accreta. I should not directly rely on it with that. It's a operative finding.
Okay,
Yeah,
go ahead.
I have to arrange the blood for her, blood and blood products before I need to stabilize her when she's in shock. I need first of all her vitals to be checked and her blood. She has to be settled first, and then I would take her immediately, simultaneously, for the surgery.
What will you tell the patient's relatives? Madam,
Yeah,
she's coming to you for
one of
regular checkup, and
one of them-
how she has collapsed in your hospital. How can you, you are advising cesarean section. We are not getting the baby also. So much of stress.
These everything has been told to the relatives, and counseling has to be done. Written consents has to be taken for the baby as well as mother.
Okay, so let me clarify here. Varsha has discussed it. Only one point, absent RP leg is a diagnosis of ultrasonography with good resolution sonography and expert sonologist. Placenta accreta is diagnosed with great acumen and accuracy. There is no need of even MRI. That is what the evidence says. Only when you have excessive obesity and when the placenta is posterior, you may have to go for MRI. So ultrasonography diagnosis of absent RP leg, when you suspect, you have to confirm. So once again, you confirm that it is placenta accreta. So once you have this diagnosis, how she will proceed? She has already, naturally the patient has collapsed. So you have to open her up. There's no other option. And for that, of course, you have to arrange for the OT, blood and blood products. Meanwhile, you have to counsel the relatives. But the counseling is not complete yet. I want somebody else to speak about the management of this patient, the operative part of it. Anybody? Reshma or anybody who wants to take up?
Yes, ma'am.
Dr. Vivek, I think we have not heard from you. We would like to hear from you. Dr. Vivek, is he here?
Yeah, I can add it.
Yeah, like can I say
Yes,
here?
Right.
She's 30 weeks.
Yes, anybody. Is Dr. Vivek here? Dr. Vivek or Dr. Surya Kumar?
Ma'am, myself, I think this being first, we have to resuscitate this patient. Being she is collapsed, we have to make stable by giving her crystalloids. We have to make the arrangement of the all blood component. We have to take a proper consent because she is a case of placenta.
What consent? That is what I'm saying. That the consent
We
is not
hysterectomy. Consent for hysterectomy is mandatory here.
And like internal like the artery ligation.
Yes.
In this particular case.
So let me give you the message here.
I
Once
just
you
want to add
diagnose,
something.
Yes, Monica.
Like
please.
consent, when you are highlighting for consent, I think consent for hysterectomy needs to be taken here because
And
it's
not
a case
as
of
emergency.
accreta.
Yeah. Not
And another thing
if
is,
needed.
another thing I want to say, like she's 30 weeks. The
Yeah.
status of the fetus is still not known, and as a priority, we need to stabilize her first.
Yes.
So so what is the hurry or the need to open her up immediately once it is? I mean, we can always stabilize her, see the fetal status, what it is,
the patient is
and can be by time.
Once, Dr. Monica, I would interrupt you here. It is saying that she started bleeding significantly and she has collapsed now. Okay, she is bleeding. So there's no question of waiting and going ahead, right? We can't wait and take this pregnancy further from this point of time. Okay, we will come how you could have prevented. That point we will take up. But here you cannot take this pregnancy ahead and you cannot wait because she is already collapsed. You have to resuscitate her, get blood products, get OT ready, and you have to,
That
do
is
the
the difference
definitive
between
procedure. Now I'm asking you what definitive procedure?
I will go for
you get
classical
little bit
cesarean
of
section.
time to assess the fetus. In placenta previa, you don't have time. You have to rush and take the patient simultaneously.
Yes. Okay.
Madam,
that is one.
Yes, first thing, I would like to just mention one thing, ma'am. As patient is coming second time to you, and there is a history
No,
of
we are not.
repeated bouts of bleeding.
Reshma, wait. We are not going for that discussion. Prevention. We are waiting for that. We have to manage this patient who has collapsed. Okay.
opening this patient, Sneha, I would like to just add that you can go ahead and doing a prophylactic internal ligation or systematic devascularization before opening. You can do
Ma'am,
that.
she
When
required
you are
classical
keeping in
cesarean
mind that
section.
it's a placenta accreta, you can do that one, or you can directly straight away placenta previa hai, or you can take a vertical cesarean section. Don't go to the placenta.
Yes.
So classical, you take out the baby and then try to remove the placenta. If it is not removable, just keep the
No.
placenta
No,
where it
no,
is.
ma'am.
No.
I want to add one thing.
Yes, please.
In all cases,
Everything is correct, only not to make any attempt to separate and remove the placenta. That is not allowed. Okay, Dr. Surya,
Yes.
go ahead.
There are
all these
studies
cases,
which says when you do a systematic devascularization,
We will come to
there is
it, Varsha.
possibility
When you
of
can do
removal.
that, we will come to it. There is a clear-cut evidence that once you diagnose placenta previa accreta, the patient is bleeding. There should be no attempt to separate the placenta. There's no question of leaving the placenta. You know, previously, I remember we have done some cases that you keep the placenta in situ. Maybe you give higher antibiotics. Maybe you give, methotrexate. So many other things. Let me share with you that I will not share any case, but lots of experience we have. It's a hanging sword on your neck, on your head. Anytime she can bleed torrentially, anytime she can go into septic shock. So never to do this. Evidence doesn't support this. That is one. Secondly, evidence says that once you are sure that you have confirmed the diagnosis of placenta accreta, you will not make any attempt to separate when it's a complete accreta. Okay, complete accreta.
Complete
That's
accreta.
I tell you. If it is
Partially
a
or
patchy, if
1/3
it
of
is
the
a patchy accreta, then there is
yes.
something called as what is labeled as triple P procedure. Okay, so that is called as mapping of the placenta, then stepwise devascularization, and then you do the myometrial resection and then you close it. Okay, so patchy myometrial resection. Okay, so these are
conservative surgery.
But this happens only when the patient is, first of all, the placenta is patchy adherent. One. Secondly, she is only primary and maybe she is not even getting this baby. You want to conserve her uterus. And the lady, she is not bleeding, she is stable. Okay. Then only you can go for these conservative procedure. If it's a question of torrential bleeding and the patient is in shock, then mother's life first. That is what, and that is how obstetric hysterectomy is the procedure of choice. So we have discussed the first line treatment, and we have discussed in exceptional situations, maybe you can go for conservative surgery, what is called as triple P procedure.
I add one word.
Yes, please.
All these cases, when once diagnosed placenta accreta, you have to go for classical cesarean section.
Yes, of course, that we have said. Not only that is where the importance of mapping the placenta comes, that you take an incision which should stop short of the placenta. Okay, so it's a vertical or transpondal incision, not even vertical sometimes. Okay, so you just remove the baby, don't touch the placenta, and just go for the obstetric hysterectomy. Okay, so what precautions you have to take during the surgery and before the surgery? What special precautions you have to see that the senior obstetrician is available. I would say not only senior but experienced or expert junior also who is well versed with obstetric hysterectomy. The senior obstetric team is there available, senior neonatologist, and of course the blood and lots of blood and blood product, because here they may be you may have to initiate the massive transfusion protocols. And then of course
we can think about abdominal aorta clamping also in few cases.
If at all she bleeds, then of course what is that Piley's clamp for abdominal aorta clamping. Okay, but then if she bleeds, that now comes to the preventing aspect. Reshma, this is your part now. Do you think that this could have been preventable? So if you think of the early pregnancy, this lady who was registered with somewhere, she had episodes of warning hemorrhages once or twice, okay, before she came to you during 6 months. So she had warning hemorrhages, and then of course you saw that anomaly scan, everything is fine, only the placenta is low line. Do you feel that the prophylactic os tightening could have been done for this patient?
Madam, it
Yes
was
or no? Yes or no?
proposed. No, ma'am, I won't go because it was proposed that there is a role of cervical encerclage, but there is no sufficient data or evidence to support effectiveness of the cervical encerclage, importantly.
I would
And
say
even
there is a evidence that against it, in fact.
yes, and
Yes.
even madam, if we consider role of tocolytics, there is also no significant effect for the prolongation of pregnancy in case of placenta previa or accreta. So both I won't recommend.
Okay.
I won't go
So
with it
first
because
and foremost,
guidelines doesn't support it.
Yes. So first and foremost, prophylactic os tightening never to be done unless you have the short cervix that is less than 2.5 centimeter. So not for placenta previa. If it was a short cervix, along with this, could have thought of. Secondly, tocolysis, a strict no. Tocolysis is always only for 48 to 72 hours, where you want, the rationale of steroids to be and magnesium sulfate to be given. But here, he is bleeding torrentially, so there is no role for tocolysis. Initially, also, long-term tocolysis is not allowed. People have said that it is, it is maybe the cause for pulmonary edema. That is what it has, especially the isoxaprines. Okay, so that is why a strict no to tocolysis, long-term tocolysis. What precautions, Reshma, this patient had come to you for the first time during 6 months, where she has had only little bleeding and she has stopped. What precautions you should have advised her, whether she was to be sent home and called her after 1 month, or she was to be given some instruction, advice, hospitalization?
Yes.
Okay, let me know.
First and foremost, some important tips to her, like avoid sexual intercourse, avoid digital manipulation, lifting even more than evidence says more than 20 pounds weight is also not avoided. Even standing more than 4 hours was not allowed to her. So moderate strenuous exercise are not allowed to her. So bed rest will definitely help in these cases, like with to avoid the early separation of the placenta, one thing. Very importantly, even if she stays away from the tertiary care center, or as patient compliance is poor, then we might think of an admission of a patient, because at 26 she's having history of repeated bouts of bleeding, one thing, and second, the UHG is suggestive of accreta. So we might consider institutional delivery. There is might be a role of elective. Here she has delivered early, but if we counsel, like if we intervene, if we have an interventional radiology department, and then we can go ahead. So counseling part should be done prior, all the things like institutional delivery. If there is a possibility of interventional radiology is there, like uterine artery embolization, those all things we should counsel beforehand.
Yes, I think with hospitalization and all these instructions, we could have prolonged this pregnancy a little further, maybe around 34 weeks or so. And meanwhile, we could have given steroids and
Steroids and even
after 28 weeks of gestation, one dose of steroids should have been
yes
that
managed.
means a complete dose. 24. Yeah. So that is what I'm saying. These all instructions, along with hospitalization, steroids, and magnesium sulfate, we could have, prepared this fetus to come out. And then we could have decided to deliver or do elective cesarean section at 34 weeks, if allowed. If not, even earlier, the baby was ready. Otherwise, we could have done cesarean section. And then, of course, you have to go for obstetric hysterectomy. But not in the emergency, as an elective procedure when things are, well planned, well prepared. So what RCOG says that whenever you are doing the anomaly scan, you have be sure about the location of placenta and also the RP leg. So that is a time, especially this lady who has had previous one cesarean section, she was very high risk for, accreta. So we have to keep this thing in mind, that whenever we send our patient to sonologist for routine ultrasound, or maybe to tackle any scan, I would say for that, even at 11 to 13 weeks, the sonologist can diagnose the presence or absence of the RP leg, and that is how we can, label this patient as having the placenta accreta spectrum or some sort of morbidly adherent placenta, and we can keep a watch on this patient and advise her accordingly. So I think we will not go into all these details. We have already said that what precautions we should take, and of course how you should proceed for hysterectomy and all this. Only for Percita you need little extra efforts during the procedure. What about the coagulopathy, Monica? How will you
So
manage
if at
this?
all this patient has reached the stage of coagulopathy, that means all the measures of PPH or atony or hysterectomy, we have delayed the decision of taking hysterectomy is what I feel. So if she has progressed to the stage of
If I just
coagulopathy,
add
and
you
in
here
case
that sometimes even with hysterectomy, even when you have done hysterectomy, the
a
field
timely
is closing.
timely hysterectomy can definitely prevent this patient to move towards the coagulopathy. And in the meantime, parallelly keep checking for the investigations of get a D-dimer, fibrinogen, platelet levels down. So at least we should predict, will this patient move towards consumptive coagulopathy is one thing which we have to keep in mind and investigate accordingly. And once if you see that the parameters are getting APTT, PTIN are deranged and fibrinogen levels are going down, D-dimers are going up, platelets down, then we have to start ordering for all the blood products, components, FFPs, cryos, platelets, and preferably whole blood if we can get, because there's already an hypovolemia. And if whole blood, less than 3 days, a fresh whole blood can give you lots of plasma in that. So consent once again has to be taken, seriousness have to be explained. And at the same time, once we order all these and start infusions of all the products, important is we need to take care of her renal functions, which most of the times we might tend to ignore because of the hypovolemia. There can be a silent renal shutdown also. So always monitor her urine output and look for the urine output, and see that the renal perfusion is well maintained. Maintain the blood pressure. Diastole always to be above 60. If it goes down, then the renal perfusion starts getting hampered. So we need to take care on that area also.
Dr. Monica, is it only the volume replacement when the patient of hypovolemia?
No, you need to have FFPs, cryo, platelet, and whole blood, or
factors.
1:1.
Yeah, but
or
what
FFP,
I mean to say
240 ml, cryo 5 to 10.
For shock, what all things you have to see? Is
you
it
have colloids also.
Do you
Till
give
the blood
IV
comes, colloids are there. Colloids are more preferable here till the blood and the components arrive. So once the components arrive, start putting in. So one side the colloids gone, the other you have two established lines, the other the components start going.
Okay. So the message here is only that you have to take care of not only the volume, but the hemoglobin concentration, that is the oxygen carrying capacity, the coagulation factors, the protein, and also the electrolytes. Okay. So the volume means everything. So you have to infuse and evaluate for all these things. Okay. That's the reason you have to timely monitor with all the investigations. So once again, we come to you, Dr. Surya Kumar. We have this fourth gravida, para 1, with 3 abortions, and now 2 empty 1 missed abortion. So she has, 2-3 abortions, I can say. Uneventful antenatal record, normal ultrasonography, fetal growth in Liker. And this patient, she got admitted around 11 p.m. in night in active labor. She delivered the healthy baby around 4 a.m. in the morning, but the placenta failed to deliver. You waited for around 40-45 minutes. Still, the placenta could not. You have tried. Everything was tried. It is mentioned here. The active management of 3rd stage of labor was also done. But then this patient suddenly collapsed. And the pool of blood, the pulse BP not recordable. What is your diagnosis here in this case?
First of all, this here 3rd stage of labor has been prolonged. One thing. We have to think about the retained placenta and uterine inversion simultaneously, because she is going into sudden shock. So it is a classical case of uterine inversion because of neurogenic shock. First of all, if you are able to diagnose immediately, you can able to reposit this uterine inversion at that time only. Here,
Yes.
first we have to take, we have to be very skillful. First, we have to reposit the cervical part, and last part to be reposited in uterine inversion is the fundus.
Yes.
If this measure fails and your cervix gets contracted, then we require exploration under anesthesia and reposition.
Okay. So for Varsha, suppose this, the patient immediately it could not be reposed. As Dr. Suryakumar said, the cervix got tight, you could not negotiate the ring. So what all measures you can take? What
First
other
of all, the patient is in a vasovagal shock. First of all, you have to correct and give her atropine and call for help. More important, fluid have to be started, ABC. And if it is not, you cannot reposit it, you can very well stabilize the patient and take her into the operation theater. Very important. And then under anesthesia, you can try to reposit it. Or if it is not possible, then you can go ahead doing laparotomy and then try to reposit it.
Yeah. So it's not only the inversion, along with that, she's also having the PPH. So you have certain conservative measures you can try, but if that doesn't help, then Rishma, should we take up this case or should we stop?
Yes, ma'am.
Yeah.
We
So
can
we have this grand multipara admitted to emergency ward, and she is a case of obstructed labor. Pulse rate is 110, blood pressure is 130/80, maternal exhaustion, and thick meconium stent lager. So you have given her prophylactic antibiotics, and decide she has to be taken for immediate or emergency cesarean section. When you did her cesarean section, there was little extension on one side, but that was sutured well. There was no bleeding intraoperatively, and after shifting to postoperative ward, also the things were all right. She had no external bleeding, but suddenly she went, she became pulseless. The pulse was very thready. Respiration was disturbed. She was having confused, drowsy look, and tendency for vomit. So, what is your diagnosis for this patient, Reshma? How would you put a differential diagnosis here?
First thing, she is with her obstructed labor, followed by with her exhaustion, followed by LSCS, and then she went in a hypotension with a third pulse. So my first differential diagnosis is a hypovolemic shock, because fall in arterial pressure is always during shock state. It's usually delays, maybe a delayed phenomenon. So first and foremost, I would like to have an ICU management like CVP monitoring and
I think
solution.
we will ask you to complete your differential diagnosis first. You were saying one is hypovolemic shock. Now, what kind of hypovolemia you are suspecting? The patient did not bleed intraoperatively.
Yeah, but madam, she was in obstructed labor, so maternal exhaustion. So at that time, she must have with a dehydrated.
Okay. One. What else? It's a non-hemorrhagic shock, right?
Yeah, non-hemorrhagic shock.
Okay.
Cardiogenic shock due to the
what for? Because of what? She is in shock, hypovolemic shock, that you mean to say. Now you don't have anything in your hand. She's not bleeding. So what you have to do is put in 2 IV lines and you start.
Just crystalloid. First, I would like to start a crystalloid.
That is okay. That everybody will do. Put in 2 IV lines and push DNS and Ringer's lactate from both the sides. That is okay. But how will you diagnose? Because you don't have any clue.
To diagnose.
CVP.
We have to go for
There's an infarct.
Must be
ultrasound is done and it is absolutely fine.
Embolism.
CV.
Because she has a disturbed respiration, pulse rate is steady. It may be a amniotic fluid embolism. Think of this.
Madam, it is after
There's
2
a confused
hours. So
look, drowsy,
only after
vomiting
1 hour.
tendency. It's a vomiting tendency. in fact, in the brain, I mean,
Okay, so
that
now,
needs to be taken into
think
consideration.
very simple. Okay, think very simple. Grand multi, 4 kg baby, obstructed labor, okay, dehydrated. Think of something, bedside investigation. You do hemoglobin, that is 11 gram%.
We have to go for a sugar.
Yes. See, the sugar is very high, 600 around. Urine sugar is 3+. You do dipstick, you do, glucometer, you check her sugar levels. Okay. And here you find, because she is dehydrated, that makes her more prone for ketoacidosis.
Diabetic ketoacidosis.
Yes. This is a case of diabetic ketoacidosis. We know how to manage. We take help of, physician. And of course, the only message I want to give for this case is always do universal screening for every pregnant woman during every pregnancy. Okay, it's not high risk screening. Obesity, age about 35 years, PCOS, nothing, family history of diabetes. No lady for high risk screening. Every woman during every pregnancy, you have to go for one step, 75 gram OGCT or OGTT. Okay, and you have to do it at the very first point of antenatal contact, that is first ANC visit. And if that is negative, 24 to 28 weeks. And if that is on the higher side but negative, then you have to repeat it at 36 weeks. That is 32 to 36 weeks. Okay. So this is, of course, you have to see that, dehydration you have to avoid. You have to go for fluid replacement. And then, of course, you have to start on insulin. So I'm not going to discuss all this because we are not supposed to do this without the help of physician to be very safe medico-legally. Okay. So even if you know this, for this critical patient, you will invite the physicians and help first, and then you go ahead with the infusion. You can give, 10-15 units of insulin as a infusion by the time he comes, and then once you are sure, you can give bolus. He can give bolus in front of you. So that is how. And of course, potassium deficiency is a very characteristic feature. So you have to give the Kesol as well. So only thing is you have to equip yourself with knowledge and equipment. The baseline investigations, even today, BTCT, clot retraction time, in Sassoon, Varsha must be remembering, we used to hang the bottles, at the wall to look for the clot formation and clot retraction. So even APTT and all these things came later, but the reports come before that. We are aware of all this, So that is how, if you should have the basic knowledge, you should implement it. And every obstetric unit and every person of the obstetric team should be trained and skilled to manage the maternal collapse. There's no time for referral or wait for somebody's help. Just call for help. Anybody and everybody should come and help. And you should, identify your staff that who will do what. The sisters who are expert in putting IVs, they will put IVs, they will send the laboratory investigations, and as per your information or guidance, they will start the IV fluids. Somebody who you assign will talk to the blood bank and keep everything ready. Somebody will call the anesthetist. So that is how you have to keep, team ready, rehearse. So you have to continuously do the mock drills, and you have to repeatedly do the mock drills, evaluate their knowledge and practical, technical skills, what they have, and you have to improve on it by the repeated trainings. So I think the team should be able to manage effectively there and then only. Otherwise, referring such patients in a critical situation, can be disastrous for you and for the patient as well. So with this, I thank all of you for your wonderful contribution to this panel discussion. And I thank all the societies and all the panelists here. I would thank especially the presidents and secretaries of Miraj, Sangli, Dr. Suman Kulkarni and Dr. Pradeep Dorle, and also the Dr. Vilas Padkare and Dr. Kiran Sonwalkar, and all of you for contributing wonderfully for this panel discussion. I hope at least few messages you have gathered from this practical discussion, and I'm sure it will be helpful for all of you for your practical, day-to-day practice. So with this, I thank everybody, and I take this opportunity to seek your blessings for my candidature as FOXY Vice President. The elections will be in August. All of you know that, and all of you know me also, my work. So I request all of you once again. Thank you so much, and over to you, Monica, once again.
Thank you, ma'am. It was an excellent panel discussion. It was like a cherry on the icing of the cake. I am thankful to all the participating societies, including Satara, Sangli, Miraj, and Y. Suman sir, Pradeep sir, Sheetal Kaur sir, you were always constant and encouraging, and you have always given us all the names instantly. Thank you so much for helping us put this program together. We also would like to thank Sunita Tandulwarkar madam, Parikshit Tang sir, Kiran Kurkoti sir, Bipin Pandit sir, Sagar Kataria sir, and Girish Mani sir for being there for the inauguration of this webinar. PK Shah sir and Shantanu sir have given their excellent deliberations. I would like to thank all our chairpersons and the panelists for today for joining in and giving their excellent academic inputs. Last but not the least, thank you to Shield Pharma and Sahitya for the technical assistance for this program. Thank you, Sneha ma'am, for the opportunity to coordinate this program.
Thank you, Monica. Thanks
Thank
for
you,
your
Sneha.
hard work.
Thank you very much, ma'am.
Webinar.
Thank
Even I
Hi,
take this
Reshma.
opportunity.
Kaisi ho?
I take this opportunity to tell you that I am contesting for MTP committee.
I was about to say that.
All presidents,
Yes.
my namaste.
Yes.
Thank you so much.
Thank you very much,
Yes.
ma'am. Thank
Thank you,
you.
ma'am.
Yeah, and I'm
Thank
very
you, Reshma
happy.
ma'am. Thank you.
Yes.
So all the best for
Thank you,
all the
Monica
ones who
ma'am.
are
Thank you, Reshma
contesting.
ma'am.
Yes, I'll be coming to Satara, Sangli soon, and
Yes,
hopefully,
100%, ma'am. We are waiting.
Yeah, waiting for you, madam. Thank you.
Thank you so much. Thank you. Good day.